Hello, welcome to you all. I'm Roy Noble, and it's a great privilege and pleasure to be here as a Bevan Commissioner on an auspicious occasion. Rosio cynnes I chi gyd. Nawr ni di dod fel casgliad ar ddwrnod arbennig gyda'n gilydd. It's the showcase for the Adopt and Spread program, supporting adoption sites as they take Bevan exemplar innovations and innovators right across Wales. I've always been intrigued with innovators indeed. Where does the idea come from? Does it build slowly in the mind? Or does it gradually, catch you unawares and a flash of inspiration in the middle of the night where you have to write it down on a paper before it actually goes? Now, when I was a young boy of 11, there were certain methods to help your innovation and to help your persistence, which is also something you need when you get an idea. And it came at the age of 11 when we tried the exam for the grammar school. And if you didn't show, a full 100% capability in the class, your parents got worried that you might not get to the grammar school. And they would try and add incentive, like, if you pass, you'll get a bike. Or if you go to the grammar school, the uniform is brown. If you fail to go to the secondary modern, where the uniform is navy blue. You've never looked nice in navy. But the great threat was that if you had ability and you were not firing on all cylinders, there was something that could be done. You could be taken to a specialist lady who specialized in the old medicines of the deep far country in Carmarthenshire. And she would do it to you. You would be taken to her parlor and she would have three things in there: a bowl of hot water, a knife, and a towel. And she would cut your ear behind the ear until it bled. The belief was that once the blood flowed and was released, all your innovative capabilities were released as well, and all your intelligence was released as well. And you could become an Einstein overnight. And if you were very thick and took, she'd do both sides for you. Actually, we never talked about it in case the police found out. But if you go to my village now, have a look around for boys my age who can't keep their glasses on. They probably have had it done. Now then, the Bevan Commission, if we can go back to that, the Bevan Commission has been leading the National Adopt and Spread program across Wales over the last 18 months, building on the work over the last 5 years with the Bevan exemplar innovators indeed. 15 of the Bevan exemplar innovators were selected to share their innovations with a new site, and over 50 new adoption sites have taken on one of those great innovations forward. Over 150 people have been involved in the adoptions and spread of innovations right across Wales as well. Now, let's not forget, this work has taken place during COVID-19, and the participants have had to work exceptionally hard, over and above what they normally do. This is the extra mile. And it's, to make that impact and to ensure that we all learn from the program. In the mechanics, there is a panel of project members who participated in the Adopt and Spread program with us today, plus guests. They will be ready to answer questions. So put your questions in the chat box, and the host will make sure that the question is asked and then answered, hopefully. So be ready then. Be interested, be enthralled, and be inspired by what we have today. Diolch yn fawr iawn.
Welcome everyone to this session. The Adopt and Spread programme is a groundbreaking programme invented here in Wales. It brings together professional networks from across the whole of the healthcare economy to share innovations that were derived from our very own Bevan Exemplar programme. These achievements are very impressive, given the fact that we've endured a period of COVID, high levels of stress, and redeployment of staff. So the gains that have been made by each of the programmes you'll see today are truly impressive. You'll see overall 13 Bevan Exemplar innovations, over 40 active adoption sites, involving 150 people supporting each other to improve performance. This is something quite exceptional and quite inspirational. The Bevan Commission would like to applaud all of our exemplars and all of the members of the Adopt and Spread programme. Please remember to do support Bevan, do tweet and message during the day, and share your best practice, because this is the true heart of what we do at the Bevan Commission. Thank you and enjoy your day. I'll hand over to your host.
Hello everybody, my name is Anne Taylor. I'm a professor in the School of Medicine in Medical Education. I'm also the Postgraduate Director, and all my scholarship and research activity has been in the field of chronic pain. I'm delighted to chair this A&S showcase. As already been stated, these people have managed to work through COVID-19 with this new service to provide timely care for individuals who require urgent pain interventions. Their efforts to learn from each other and work together is incredibly noteworthy, especially as pain is a highly prevalent and debilitating problem amongst people with advanced progressive cancer and non-cancer diseases, with over 50% at some point reporting severe pain. And the prevalence may increase as these individuals approach the end of life. And this is a major concern for healthcare professionals, and it is a global health priority. The panel are excellent role models in how to involve trainees and in their passion to advance and support excellent patient care. And I will now ask each of the panel to introduce themselves. So if we can start with Steve, please.
Hi, my name's Steve Hill. I'm a planning radiographer here in Velindre Cancer Centre in Cardiff. I'm a previous Bevan exemplar and have been working towards palliative radiotherapy advanced practice for about 12 years.
Thank you, Steve. Ashley?
Thank you, Professor Taylor. So my name is Ashley Poonking. I'm one of the clinical oncology registrars. I've had the pleasure of working actually both in Swansea Bay Health Board as well as Velindre Cancer Centre, and I'm currently based in Velindre Cancer Centre and was involved in the sort of trainee involvement in setting up the palliative.
And Christine.
Hello. My name is Christine Silman, and I'm one of the lead radiographers in the CT simulator in the radiotherapy department at Singleton Hospital in Swansea. It's been a long-standing aim of ours here to set up a radiographer-led palliative radiotherapy service, and I'm also a previous Bevan exemplar and have come on board with Steve's project in adopting and spreading this to the whole of Wales, to the 3 centres, which I think is obviously the gold standard to have this system working throughout Wales rather than individually.
Thank you very much, panel. Sorry, I was just checking to make sure I wasn't on mute. We should learn that about mute by now. So I'd just like to introduce now the next video about the actual project. Thank you.
Palliative patients, when cancer spreads, often have serious symptoms. For example, uncontrolled pain, where their pain medicines have stopped working, bleeding, neurology, when they lose the function of their bodily functions, for example, their arms or their legs give way, can have a severe impact on their quality of life. What we're trying to do is improve palliative radiotherapy treatment pathways across Wales by upskilling radiographers and setting up new rapid access palliative radiotherapy clinics. This ensures that the right patients are seen at the right time by the right people with the right skills. With the Bevan Commission's Adopt and Spread scheme, we secured £45,000 of vital funding. This was shared across the 3 cancer centres across Wales. This has allowed upskilling of radiographers with the vital MSc advanced or consultant practice skills, and this gives them the right skills to help patients at the right time. In Velindre Cancer Centre, Cardiff, we have used the funding to start a rapid access palliative radiotherapy clinic. This has improved the palliative pathway with real benefits for symptomatic patients who need urgent access to palliative radiotherapy treatment. So far, we have seen over 150 referrals into the palliative service. The main focus of this clinic is to review the patient for consideration of palliative radiotherapy. although the clinic can also support patients who need urgent general oncology review to support decision making, overall care plans, and links to cancers with unknown primaries to help their patient pathways. In Cardiff, we're also upskilling 2 radiographers with palliative advanced practice skills. What we found is the referrals have helped teams such as other doctors, such as the palliative care team or medical oncologists who don't do radiotherapy, who have quicker access straight to the palliative radiotherapy team. It has also improved other patients' experience by teams not double booking a patient into an already busy outpatient clinic, so it doesn't indirectly affect other patients. It's also helped the on-call team. For example, when they are dealing with an emergency patient, they can screen the patient, and if it's more urgent, not emergency, they can divert patients away from already busy emergency services. We're also spreading this innovation up to Glenclwyd Hospital in North Wales, as they are just starting their advanced practice journey. So have started 2 radiographers upskilling in palliative radiotherapy. In Singleton Hospital in Swansea, they are also doing both of these key improvements. They are starting a palliative radiotherapy clinic with Chris Silman alongside the medical team there. They are also upskilling the radiographer into learning new skills, which is vital when seeing the patients with urgent symptoms. Well, why are we doing this? We're really doing it for the patient. We're trying to improve the pathway with real benefits for symptomatic, urgent patients who need radiotherapy quickly.
It's going to reduce my pain. It might put it up to start with, but that the idea of the whole exercise is that the pain would reduce, and I'm happy with that.
We're offering a rapid multidisciplinary team approach and an oncology assessment with the palliative radiotherapy team. This includes a radiographer, a medic, and the therapies team. We're improving patients' experience by reducing hospital visits, as most patients have their planning scan on the same day as the palliative radiotherapy clinic. We can also expedite their palliative radiotherapy treatment, which reduces the referral to treatment time. For example, a patient who needs 1 shot of radiotherapy or 1 fraction can start their radiotherapy treatment 2 days after the decision to treat date in the clinic. The patients are seen then at the right time by the right team with the right skills. The team are able to plan their radiotherapy treatment after the clinic on the same day, which reduces staff stress further along the pathway. It's also a teaching clinic, so we are improving palliative radiotherapy teaching to radiographers, junior doctors, and other healthcare professionals. This includes patient assessment skills, radiotherapy planning skills, communication and dictating skills. We're using a national Bevan Commission and GP pro forma to improve our communication skills back to the referring teams. If you need any further information about this innovation, contact us on the email below.
Well, I'm very remiss as a host. I didn't ask Brian to introduce himself. So sorry, Brian.
No problem.
Please, could you introduce yourself? We left the best to last.
I'm Brian Hewitt, pre-treatment therapy radiographer up at Glenclwyd in the North Wales Cancer Treatment Centre. We've been looking to develop a radiographer-planned, radiographer-led palliative clinic for quite a while, which never really got off the ground. But as we've joined with Steve, with the help of the Bevan Commission, it's starting to kick off now.
Lovely. Thank you very much. So please feel free, everybody attending this, to add some questions into the chat function, and I'll keep an eye on that. I'll kick the session off with asking some questions myself. So I've got a list of questions that I've put together. We've put together. So from the point of view of a patient, please can you describe the palliative radiotherapy clinic for me?
Yeah, so patients present with quite devastating and very urgent symptoms. So they could present with uncontrolled pain, where their pain medicines have stopped working. They could be bleeding, or they could have some sort of neurology where they lose the function of their arms or legs, which can be quite distressing. Now, this could be presenting to their oncology team, or the palliative care team, or even their GP. They may be known to an oncology team, so known to a cancer hospital, or with a known diagnosis of cancer, or this could be their very first presentation. And most patients we've seen need a face-to-face oncology assessment, as seeing the patient in person helps when assessing the patients with these urgent symptoms for clinical assessments. So the referring teams have seen the patient and have sent a referral form or an email to the palliative radiotherapy team. We screen the patients to see if they meet certain criteria to be treated as an outpatient, and then our admin support book them into the rapid access palliative radiotherapy clinic. They also book them a planning scan on the same day, if that's possible. Over 90% of our patients in the palliative rapid access clinic have actually had a planning scan on the same day, which saves an extra hospital visit with less CO2 footprint. Most of the patients we've seen have received a single fraction of radiotherapy very soon after the clinic. This is wholly an outpatient service. More than 90% of the patients we've treated without an admission into hospital. Now, we've involved the patients and we've asked for some feedback from the palliative radiotherapy clinic experience and some patient quotes. They've said, the rapid response to my referral has been impressive. The various expertise of the team that provided clear information and advice, the clarity of the plan that was agreed. Another patient said, a very efficient service. Staff were very professional with a personal touch to be proud of, always a sense of calm and composure. While another said, they made me feel at ease and all the information was given in a way that was easily understood.
Thank you. That sounds very impressive indeed. I think, when you're facing a painful crisis, you do need people to make you feel very reassured and that everything's in hand. So for the work that has been taken place in Velindre, can you please tell us a little about the types of people that are referred to your service?
So over the course of the clinic, we've received 147 referrals, and we've provided clinical review for about 134 patients. This largely is patients suffering with cancers. Most common ones are lung, breast, and prostate cancer. On average, about 4 patients are being reviewed in the clinic each week. Over time, though, we are seeing an increase in the number of referrals. The source of the referrals is varied. We have a mixture of referral sources. So we have some from our medical oncologist colleagues. So medical oncologists, as opposed to clinical oncologists, do not prescribe or involved in the planning or prescription of radiotherapy. So they often need support from the clinical oncologist to provide radiotherapy as part of their treatment. We've also had referrals from consultants that are part of the shielding group and unable to be on site to physically review the patient, make that assessment, and plan their radiotherapy. But a quarter of the patients that we received were actually completely new to Velindre. So they may have come from home, referrals from our community palliative care colleagues, referral from some of our other medical specialties. And it was identified that these are patients that are suffering significantly with symptoms of cancer that may benefit from some palliative radiotherapy input. So it was a route to be able that we were able to sort of see these patients and provide that specialist input. it was a facility that allowed as well a sort of quick assessment. So, for example, we may receive a referral, say on the Monday, for example, be able to be screened, slotted into the clinic on the Wednesday. So within 2 days, that person would have been able to be reviewed by an oncologist. And it also supported our clinical oncology colleagues who may be having issues with sort of very strained resources with regards to their outpatient clinics, or they were on leave, so that there weren't delays to those patients being seen and treated appropriately.
Thank you, Ashley. I mean, the psychosocial sequelae of having severe pain, we all know is huge. So actually to get in there quickly, things like depression and anxiety and, not being able to sleep and stress and being able to integrate with your family are all kind of positive side effects. Just before we go into more questions, I'd just like to introduce Mick, who was delayed because he was actually seeing people in clinical practice. So, Mick, if I could just ask you to introduce yourself, please.
Yeah, I'm really sorry to come in late. I thought I'd planned my clinic this morning, but life had other plans, and patient care's got to take first priority. So I'm one of the clinical oncology consultants at Velindre, who's been working with the team, working with the Bevan Commission as well, Steve and others over the years to try and develop this. And really great to have this opportunity to thank the Bevan Commission for their support and thank colleagues in Velindre and outside and discuss and share the work we've been doing. I think there's a focus in the clinic on the radiotherapy, absolutely, but there's a benefit, I think, to seeing an expert cancer team. You talked about some of those psychological sequelae, Anne, and a lot of the conversations we've had have been in the realm of those big conversations around cancer diagnoses or things changing or getting worse. And yes, we do absolutely think about radiotherapy as part of a package of care, which often involves honest discussions about what the future might hold, and then communicating that with the patient or their relatives if they're there, and other care teams such as the primary care team. That's been a really big focus on what we're doing, not just kind of come and have the radiotherapy and off you go. There's a lot more to it.
Lovely, thanks, Mick. Right, I'll carry on with the questions. So during this project, who used the service? Was this the same across the sites?
So patients' referrals that we received in Velindre and Cardiff, we received from a range of teams. 49% of the referrals came from Velindre clinical oncologists, so consultants who, like we've said, may have been shielded, they may be going on annual leave, or they may have a really busy outpatient clinic already, so diverted patients into a rapid access clinic to improve patient experience. 19% have come from Velindre medical oncologists, so those doctors who don't do radiotherapy, who are specialists in chemotherapy, so they can fast track patients who need urgent radiotherapy to the palliative team. 12% were from registrars, so junior doctors learning about radiotherapy or training to be the consultants, and other referrals were from our community teams, from specialist palliative care teams, advanced practice nurses or pharmacists, and other health board teams. Out of the 146 patients we screened and saw, 123 of those patients were living at home. 15 were already an inpatient in an acute hospital. 6 were actually in a hospice, and 1 was residing in a residential home. Most of those 146 patients, 117 were already known to Velindre Hospital, so had an oncologist and were a cancer patient. And where there was a problem or planning or delivering urgent palliative radiotherapy, they diverted it to the palliative team to be seen in a timely way. 28 patients were new to Velindre service, so had never been seen prior to this episode. 82% of those patients have received palliative radiotherapy via the service, so a high proportion of the patients we see and assess need urgent radiotherapy. Out of those patients, over 90% had external beam radiotherapy on a treatment machine called a linear accelerator, while 7% had superficial treatment via DXR. So that's when they've got a cancer close to their skin. It's a lower energy X-ray machine that we can treat skin cancers or things just underneath the skin. This accounts for approximately 20 to 25% of our palliative radiotherapy patient numbers, so quite a significant proportion was delivered rapidly with good patient feedback combined with training opportunities.
Indeed, a very holistic package of care. Okay, so what impact are you going to have for the patients and their families?
Thanks, Anne. I suppose it's difficult to answer that question a little bit as a healthcare provider, because you get that answer from the patients and their families. We have had incredibly positive feedback from patients, scoring the service very highly, and very movingly also a lot of positive comments about how they've been looked after. I think they very much appreciate the speed of the service. As I say, if we can see people more rapidly, they then get answers about what the plan is, what the treatment is. They know what's happening. They've got knowledge. They've got more control over the situation, which is of value. We do, where appropriate, kind of try and develop conversations around future plans and thoughts around priorities and wishes for the future. Maybe not to finish those conversations, but to plant some seeds that can then be carried on with it, maybe the community palliative care team or the primary care team to make the next steps and things like that in terms of their cancer journey. But we'd very much hope, and I think this is borne out by some of the comments we've seen. It is a very fast service, which is appreciated. They get time in clinic with an expert team of oncologists, radiographers, trainees. We did have a representative of the therapies team when we first set up the clinic. They did a holistic need assessment of patients, but actually, they picked up that most patients were well supported in those areas already. So they dropped out of the clinic because they weren't adding very much. And we now provide just kind of paper copies of, if you have got these things, here are some contact numbers. We do things quite efficiently in terms of they come to clinic and have their scan afterwards, and then most patients go on to have just a single treatment of radiotherapy. So a lot of this is done in just 2 visits to hospital, whereas for other patients it might be, you might see the oncology team for a discussion, then you come for a scan to plan out your radiotherapy, then you have your radiotherapy. So it can take a bit longer, and it might involve more hospital visits, which could be time off work or time away from family or impact on family who are driving you or things like that. There's a whole wave of things that happens around transport. So we hope it's positive, and I think we've got some data to suggest that it has been. We were very keen to avoid any kind of negative impacts, and we had a lot of planning meetings before the clinic started. And one concern is, if I'm seeing a patient in clinic and I know them well and I can organise the radiotherapy quite swiftly, then we don't want to disrupt that when it's happening very well already. So that's been involved in the communications with the oncology teams. So if something's easy to do, just get on and do it. But if there's a problem, if you're shielding, if you're off sick, or if your clinic's full, and if you overbook the clinic, it's going to have a negative impact on that patient and others who then have to wait. Or if someone has to wait a few weeks before they can be seen, we're then the safety net that can catch people and do something very well and very quickly, which I think is a huge benefit.
Excellent. Sorry, I'm multitasking here. Give me a second. So we've got a question from Stuart Full. Thank you very much. Who's a quality improvement radiographer. Well done, he says. You've worked really hard to get where you have. What barriers did you face and how did you overcome them? And what barriers do you still face? Anyone?
Everyone's gone quiet. I think we'd like to bring in... Sorry, after you, Brian. Do you want to go first?
We found, as I said earlier on, we were looking to implement something similar quite a while ago, but there was always the problem with backfill for our substantive posts. We found that trying to start a clinic such as this and actually learn appropriately and at a reasonable level wasn't really possible without the backfill, without some acceptance that this wasn't just part of our normal working role, and it was over and above what we were actually providing at the time. And we have found with the addition of the Bevan adopted spread that this has changed. We've been backfilled now for our clinic on a Monday, and we do get some CPD time, some study as well.
Excellent. Mick, did you want to come in there?
Christine, do you want to come in first?
Well, I think I would probably agree with Brian that we have similar problems when we tried to set this up some time ago. We've been trying to set this up for a number of years, to be honest, and staffing issues with backfilling of staff have always got in the way of it, really. So I think our issues are very similar, to be honest.
Mick, did you have anything more to add?
I think I'd echo exactly the same, that everybody in the NHS is incredibly busy. There isn't any spare capacity anywhere that I can see. So to take somebody out of one role to try and do something different is tricky. I think the adopt and spread framework has been instrumental in actually getting us started on this. And thank you very much for that. We're now doing a business case in Velindre to try and, establish this as a NHS funded, core service. We're looking at what the service might look like in terms of, it's once a week at the moment. Is that the right thing? What kind of patients? What sort of service should it be? And there's some choices in that. I'm glad we have done it. There will be ongoing barriers, I'm sure, in terms of, some people very keen to use the service, some people hesitant, understanding what it is. And a lot of our work at the moment is about communicating where the service sits, how it can support. We are looking at the kind of strategic long term as well. So we've got a radiotherapy satellite centre which is due to open in a few years' time up in Abergavenny, which is about 40 miles away from Velindre. And for patients who might be having a course of radiotherapy, having that radiotherapy close to home is going to be absolutely key. That will, reduce transport times, and from an environmental perspective, it'll reduce carbon emissions because reduced travel, improve patient experience. But we've got a workforce problem of how we deliver radiotherapy across different sites, and technology will help with that. But I think having a multi-professional approach will give a more resilient workforce. And just relying on doctors to do everything is not always the best route. It's often quite an expensive route. So having radiographers coming through who can then deliver a really good service alongside a medical team helps with the future. And there's also some benefits outside of the clinic. So Steve and others help support, say, the on-call teams on different days of the week, not just on the Wednesday when we have the clinic, to if there's emergency patients who need planning, or if there's patients who need planning at other times. Steve can help the trainees, can help the consultants if we're not on site. Like I'm in Llandoch today, so I'm not really in Velindre. I'm at work, but I'm not physically in Velindre. So it helps the flow of patients outside of the clinic, and the extra training and structure that we've created through the clinic helps develop skills which are then used in other areas. Is that fair to say, Steve?
Yeah, definitely. It's impacted the whole service, not just the rapid access clinic on the Wednesday. I can only agree with Chris and Brian with backfill and the problems that each centre are having a similar theme, similar problems. But I think we're underusing the skills of our staff, and just by training the right people with the right skills can just improve the experience for patients. It's been more of a extended practice, not an advanced practice over the last 10 years. If there's enough staff in, if no one's sick, if there's no annual leave, etc., then we can do some advanced practice. But as soon as we're short-staffed, then our time gets diverted to the core services. So yeah, there are so many benefits that we could could improve, and we're just scratching the surface with what we've done so far.
And of course, the small pandemic has obviously made huge difficulties in what you're trying to do as well. And there's a comment by Lisa Lovegood. Thank you very much. So therapy teams were represented in the clinic by a therapy tech who screened all patients. When this clinic was evaluated in March 2021, the aim was reviewed. The pilot demonstrated there was a need for therapy input, albeit the self-referral route didn't generate the ongoing referrals into therapies due to patient choice and activation levels. To ensure continued delivery of information, a first-line self-management top tips leaflet was designed to be handed out. Each and every patient that attended the clinic is now given this leaflet with the contact details of each therapy team. Should they wish to seek further support, ongoing evaluation will be sought to explore models of delivery for therapy. Thank you. So we've got Nigel Deshpande, a medical physicist. So I can't read the rest of that. So for patients who are having a single fraction of palliative RT, are you considering doing the clinic planning, CT scan and treatment all on the same day?
For most patients, we've arranged the planning CT on the same day as the clinic, so that saves an extra visit for the planning scan. Most patients do come back another time for the radiotherapy a few days later. For one or two patients who are either more urgent, with nerve root compression, for example, we have tried to arrange same-day treatment for these patients. It does cause a different pressure on staff here trying to turn around treatment the same day, but it has improved things for those patients who really need it with more urgent symptoms. Most of our patients can wait a few days, so it's a case of screening the patients and assessing what needs to be done. So most of the time they come back for another time for their treatment.
Thanks,
can I add a little? Is that all right?
Yeah, sure.
Just out of pragmatism, we ended up with an afternoon clinic. That was when we seemed to have staff available and space in the outpatient department, and that limits ability to do things on the same day, because once they've had the scan, there's actually quite a lot of quality assurance and checking and planning that needs to be done. It takes a few hours. When we're looking to the future, we're looking to see maybe can we move the clinic to the morning, which would then give more opportunity for that. And it'd be an interesting thing to, I think, offer to patients as a possibility. I could see it, if you live in maybe Whitchurch and Villandra's just around the corner, you might say, well, actually, 5-minute journey, I'll come back another day. Why would I wait 2 or 3 hours? Whereas if you maybe live up in, say, Merthyr or something, and it's a longer journey, you might say, well, do you know what? I'll come down and I'll go for the all-day service. I think there was, we talked to a team in Southampton, and they were doing a one-stop all-day service. But a catchment area they've got is the Isle of Wight. So it worked quite well with the ferries to come over on a ferry and stay all day and then go back. And, geography plays a part in that. But I think ideally we would look to see if we can offer that in the future.
It strikes me that, what you're delivering is a very agile service that you're reflecting on very frequently to address the needs of the people that are coming to your service. So again, I think, that's really good practice. We've just got a couple of minutes left. So in the Vilindra adoption site, you've included registrars in this project. Can you say a little bit about what happened and why this is important?
Yes, so we use this as an opportunity for training, really. Prior to the clinic, I think a lot of us felt as though we could potentially benefit from some more formalized training with regards to palliative radiotherapy. Informally, obviously, we get training from our supervisors and from actually our treatment radiographers. So sort of Steve, a lot of us have kind of grown up using Steve as a kind of resource to learn about radiotherapy planning. And we actually got data to kind of support this. So we did a survey prior to the clinic, which showed that all the trainees did really support the introduction of this service as a potential method of training in palliative radiotherapy. And then following the introduction of the clinic, we created a rota system so that an oncology registrar was assigned to the clinic with the supervising consultant and with the radiographer. And then we collected information on how we found that experience. And across the board, in many different types of palliative radiotherapy, trainees reported that they had improved confidence in sort of assessing patients, consenting them, planning and prescribing radiotherapy. There's also a bit of a skill mix. So we've got a mixture of sort of more senior registrars versus more junior registrars. As a junior registrar, you're probably very sort of unfamiliar with radiotherapy, how you deliver it, how you plan, etc. So I think the junior registrars in particular found this really, really helpful resource. I think this will have greater importance in the future as we have some curriculum changes coming. So historically, medical oncology and clinical oncology are run by two different colleges. But we are going to have a merged first year in oncology. And the importance of that year is getting to the grips with basics of oncology care and treatment. So even for our medical oncology trainees who may have a medical oncology supervisor, as part of their curriculum, it's important that they get a grip to palliative radiotherapy treatments. So this clinic will be really vital to improve that access to radiotherapy training for both medical and clinical oncologists, as it's such a backbone of oncology treatment and care. In addition, I don't know, Steve, if you want to go into the kind of the radiographer side of it, but from the junior doctor perspective, we're hoping to expand to include our junior doctors who are not training in oncology to our SHOs that are based in Valinja, so that they have better exposure to behind the scenes, so to speak. As a junior doctor on the wards, you may not be as familiar with what radiotherapy actually involves. And this clinic gives you the opportunity to see a patient, assess the patient, potentially see them on set, understand this is actually physically what the patient goes through. This is how we deliver radiotherapy. These are the potential side effects and problems. We also had some taster weeks from some of junior doctors that are interested in oncology that were able to sit in on the clinic, and a physician assistant as well. So it's very much a multidisciplinary training opportunity. We feel that we're learning from the radiographers that are in the clinic as well as our oncology consultants. The radiographers also gaining experience from us because we have sort of slightly different skill sets. So we found it really, really beneficial for our training. But Steve, I don't know if you want to come in from the radiographer.
I'm going to have to stop you there. We've got a timetable. So sorry. Thanks, Ashley. So Steve, maybe you can pick this up after the next video. So we're going to play another video now. It's a short video before we go to the next set of discussions, and this will highlight all the projects show. Okay, so obviously Bev and Commission are very, very busy doing lots and lots of exciting things across Wales in terms of improving people's lives and healthcare. Steve, was there anything else you wanted to come in following Ashley? Sorry I had to stop you then.
That's okay. I was enjoying the dramatic music from that last video. It's brilliant. Yeah, I just wanted to echo Ashley's thoughts. You know, the multidisciplinary teaching experience that we've had over the years. Mick and myself have been teaching junior doctors, and we've both got different skills. And more recently with another consultant, but also in clinic learning, we're constantly learning from each other and teaching each other different skills. Recently, we've with COVID hitting, we've offered the clinic virtually to our Brian up in North Wales and a colleague Rebecca and Chris in Swansea. So we've shared our learning experiences from the clinic. In Cardiff, we've shared that experience with a second radiographer, Matt. We've also, you know, developed these MSc skills, but also to our radiotherapy undergrad students. So Cardiff University are interested in having some extra palliative sessions and bringing the next cohort of radiographers through, learning, you know, what can be done, what skills they could learn. We've also adapted during the pandemic and during the project, and some feedback from our junior doctors and the registrars said they wanted some extra palliative radiotherapy teaching sessions outside of the clinic. So we've also rotated alongside the clinic an extra session each week to teach these skills to the doctors that want the extra experience, the extra time to learn the planning radiotherapy skills. So yeah, it's been brilliant and positive experience so far from all of us.
Thank you very much. So what's next for each of the adoption sites then? What stages are you all at?
I think Brian's dropped out. So Chris, do you want to answer from Swansea's point of view?
Yeah, well, as I mentioned earlier, it's been a long-standing aim of ours to introduce a radiographer-led palliative service. And this has been introduced very successfully in other centres, both nationally and internationally. And it's very well evidenced in published literature that it obviously works. It ties in very well with Bevan Commission principles of making use of skills of radiographers, the advanced practice skills that radiographers have. And in fact, here, our CT Sim radiographers have for a number of years planned radiotherapy, put provisional fields on to plan radiotherapy treatment, ready for consultant oncologists to review these plans and approve them appropriately. So this project actually began for us a number of years ago with the aim of formalising this process of radiographer-led planning, and to gain the necessary modules and training to enable radiographers to approve and to prescribe radiotherapy treatment without the need to wait for the doctor's approval within an agreed scope of practice that would be suitable for radiographer-led processes. And I've now developed, myself, I now have the training and competencies in place ready for, the entitlements in consent and planning, in approving and prescribing palliative radiotherapy within a very clearly defined scope of practice. And for a year prior to COVID, I was working alongside a consultant clinic doing consultations, consent and radiotherapy planning, with the aim of developing a radiographer-led service alongside the consultant one, whereby suitable referrals could be diverted along the radiographer-led route, and with close collaboration with both consultant clinical oncologists and trainee registrars, that this could have been developed. But staff shortages, as we've mentioned previously, and further exacerbated by staff shielding and changes to clinic organisation due to COVID, did actually put this on hold for a while. It has now recently been agreed that a pilot fast-track palliative session can be implemented from within our CT simulator, whereby some suitable referrals from initially one or two named consultants could be diverted into this session for consent, scan and plan on the day. These would probably be then treated the next day, We do have a service, obviously, whereby emergency patients are treated on the same day, and we've recently set up a group on a Teams chat to enable referrals to be made in, urgent referrals to be made into that group, and often these will be treated on the same day then. Currently, I'm the only radiographer who would be entitled to carry out the service, but it's planned that one or possibly two other radiographers will be following a master's level module necessary to enable them to be able to carry this out also, and hopefully this will be embarked upon quite shortly. The palliative. These models would be, obviously in palliative radiotherapy planning, consent, and things that would be relevant to this. And then these trainees, along with trainee registrars, will work alongside me during these pilot sessions on a rotational basis. Collaboration with relevant consultants is easily achieved here because we do actually have a completely paperless. Everything now is paperless, and everything is completed electronically. From all aspects of consent, booking, approval, and prescribing is done completely electronically, and obviously can be accessed remotely by consultants. So if there's anything you needed to discuss with a consultant, then they could access that remotely, and that could be utilised if necessary. We're planning on a 3-month pilot study to be introduced over the coming months, with initially 1 fast-track session per week, ideally with a view to developing this into 2. Ongoing training of radiographers is planned, as I've mentioned, to ensure sustainability using some of the funding, and we will be doing a comparison of the data collected from this pilot study, which will be compared with the standard pathway, which will still be running alongside for other referrals. Emergency patients, as I say, tend to be treated same day anyway, and we do cover quite a wide area in Swansea. We get referrals from Aberystwyth, as far away as Aberystwyth in Pembrokeshire, and for some urgent cases, they too can be treated on the same day due to the distance they're travelling. But I believe for your fast track general palliative patients, obviously referred for pain, it's a long day for them to be hanging around waiting for treatment, as it means, obviously consultation and consent. It means the planning scan, and then to wait for the planning to be completed. Then, along with all the calculations that are necessary before treatment can take place, it is a long day for people. And ideally, I think the treatment sessions could be booked in the next day, or in the next 2 days at least, and that obviously that is still getting them onto treatment quickly, without having them hanging around the department for, the whole day, which is not ideal for a lot of people. It does also put pressure on the pre-treatment team, in working out all the calculations that are necessary before treatment can commence. So that's what we're looking to implement now over the next couple of months. This pilot study, which will take place within the CT SIM pathway.
Thank you, Christine. Sounds like it's all happening in Swansea, and I don't expect anything less being a Swansea girl. Brian, can you tell us what's happening up in North Wales and what's the future holding?
Yeah, certainly. We're a lot earlier on in the process. We only actually started this in September. We're blaming COVID for a bit of that. We were supposed to start in the April, but staffing, lack of consultants actually on site, that didn't help. So at the moment, we're still relying on referrals from clinical oncologists who have actually seen the patient and deemed them reasonably fit and deemed radiotherapy relevant for those patients. This is hopefully going to change in the future. The funding that we got from the Bevan has allowed Rebecca and myself to start undertaking a master's, and part of that is going to be patient examination and informed consent. And hopefully, once that's up and running, once we've done those modules, then we can start looking at actually bringing in patients to an outpatient appointment, and making those sorts of decisions, that level of decision ourselves. The hope is to be running this clinic as advanced practitioners. There is some aspiration for a consultant level post within North Wales, a consultant radiographer level post within North Wales, but at the moment we're just looking at advanced practice. Currently, with the MSc, we're looking at service improvement, and it's impacting not just the palliative planning clinic, but our normal palliative process as well, as some of the radical patients. We're looking at education and training of the rotational staff in the pre-treatment area, because as we mentioned before, backfill for our posts. If we do move on, then there's still going to be the need for staff at our level in our current posts. So sort of succession planning, if you like. We're looking, and that will also help other staff developments, as well as helping if we do move on to another role. And also things like reviewing the nausea and vomiting policies that we've got at the moment. Little things like that will help not just the patients in the palliative clinic, but service-wide, hopefully. As I say, the work that we've done has changed our mindset, it's changed our thought processes, not just within the clinic, but for our substantive posts as well. It's not always been welcomed. As pre-treatment radiographers, we were seen as enforcers, really, for the doctors when they weren't doing what they were supposed to be doing. But we've now come to realise a lot of the efforts, the thought process, the level of thinking that does go into just getting to the point where you can sign a referral form for radiotherapy. And we've started going a little easier on our consultants since we've come to understand what they are actually going through when they're making these decisions. That hasn't, as I say, that hasn't always been welcomed by some of our other colleagues when they're wanting us to interrupt the doctors, and we're actually acting as gatekeepers now rather than enforcers. But that's what we were here for. We were here to learn what the consultants' thought processes were when they were seeing before they saw the patients, when they were seeing the patients, and hopefully that will lead to a proper radiographer-led clinic where the oncologists are there for advice if needed, rather than actually making those sorts of decisions.
Lovely, thanks very much, Brian and Christine. So we have a question here from Laura Evans, who's a medical secretary at Velindre. Is this clinic that you think will expand further to external patients more? How is this clinical advertised to patients outside of Velindre? So do you think it will be seeing more external patients, and how is it advertised?
Shall I take that one?
Yes, please.
We certainly would like to, I think, probably increase the proportion of patients who are outside Velindre, if you like. I think we're a little bit cautious about that at the moment, where we're coming to the end of the adopt and spread money as the pilot, and we're doing the business case to try and establish it. And there are some options in the business case, many of which include expanding the clinic to be more than just once a week. I think we're on the cusp of capacity for that once a week clinic, and what we certainly don't want is a waiting list building up. Through the work, we have done some promotion for teams outside Velindre specifically. We've met with and talked with the regional palliative care teams across Southeast Wales, and we've had some referrals direct from them into us. And actually, one of the impacts of COVID was they felt that, quite rightly at the time, when there was a desire to avoid hospital appointments or admissions, patients were maybe fast-tracked home or managed without oncology input sometimes. And some of those patients were left with questions around treatment because they felt they hadn't seen the oncologist, although they'd seen perfectly capable, very skilled, very professional people. They hadn't seen the person labelled as the cancer specialist. So we've seen a few patients to support them and had those conversations, reassuring them that everything's done appropriately. And we've had some referrals because we've linked in with the acute medical teams in hospitals, so the acute oncology teams. And that's, we've had a few patients who've been referred, although this is an outpatient service. I recall one patient who was an inpatient in a hospital, and I think he was seen by the acute oncology teams on a Monday, referred on a Tuesday, seen by us on a Wednesday, and went home on a Thursday because he'd seen us and had a plan in place for treatment. So that sped up his discharge, and I think the more we can do around that, the better. Another interesting prospect, I think, which we've touched on, but if we get the business case through, I think we could develop further, is the new rapid diagnostic centres which have come through in some of the local health boards near us. So those are almost like a safety net again of urgent review. If say your primary care team have got a worry, someone's got pain or weight loss, lots of those kind of symptoms where you're worried there's a serious underlying cause. A bit like our service, they can have a very rapid outpatient review, imaging and diagnostic procedures, and a proportion of those patients are sadly diagnosed with advanced cancer. Now, if we wrap that up with a rapid access palliative radiotherapy clinic, you could see a very quick, very high quality pathway coming through a rapid diagnostic centre, rapid radiotherapy. And about 40 to 50% of these patients with advanced cancer like that often benefit from some radiotherapy. We then may need to tie it up with a referral back to the specialist team, if there's a need to think about systemic therapy or further treatments. But we could have a quick oncology review and radiotherapy while we're waiting for some of the diagnostic information to come through to guide those future conversations about systemic therapy. So at the moment, we've held off that exterior promotion just while we're waiting decisions around the business case. It doesn't feel right to do a big promotional bid until we know what the service looks like, or even that it's going to continue. But I would hope with time it would grow, it would expand a little bit, and would reach out to teams outside Velindre more, and potentially even primary care teams with direct referral through. We've held off that for now, but we have done a lot of work with primary care teams again through Bevan and one of your exemplars, Elise Lang was one of Macmillan Framework for Cancer lead, who did a great project through Bevan. And I think if we've got this established, then I think we'd look to go back to the acute oncology teams, the rapid diagnostic centres, palliative care teams, and potentially even primary care teams as well to foster that referral pathway in new ways.
Thank you very much. In a couple of minutes now, we'll have our concluding video. But I'd like to say a really great thank you, Steve, Mick, Ashley, Christine and Brian, for being here today and to showcase what is a right service at the right time for the right people by the right people, or something more articulate that the Bevan Commission states. But I think it's really exciting to see these developments. I think it's testimony to how you're learning from each other. I would have thought there's lots of constructive debate and discussion that's handled very professionally. It's great that the person is at the heart of this service because, if you've got a finite amount of time left, you want to make sure the quality of your life is great. And I think you guys do that for these people because they can do things that they wouldn't be able to do if they were in severe pain or had functional loss. And I think it also leads to, you know, a biopsychosocial approach to pain management, because you're addressing the physical, but you're wrapping up the psychosocial as well around of all of this. So I don't know if any of you in the last couple of minutes have got any concluding remarks that you'd like to make. Steve, is there anything you'd like to say? Yeah,
I'd just like to say a huge thanks to the Bevan Commission. Without their help, first of all, a few years ago with the Exemplar programme, and now with the Adopt and Spread, this wouldn't have happened and developed so positively for patient experience. I think when the COVID pandemic hit, we were hesitant, we stopped, we assessed what was going on there, but it actually made things a bit more complex to plan, deliver the clinic, but then it gave us the impetus to push forward. We found patients presenting later with more advanced cancers, with more advanced symptoms, so it actually gave us the impetus to go ahead with this rapid access clinic. So it's been great, supporting the challenges that COVID threw, but more importantly for these patients going through such a terrible experience with, these distressing symptoms. So we're really thankful for your help. So thank you very much.
I'd just like to thank all those people that have attended today and listened and learned and asked questions, and hopefully, you're getting enthused and interested about actually taking innovations through for the Bevan Commission. So thank you ever so much. Nice to meet you all. And I think it's been a really good session, and I've learned a lot. Thank you.
Thank you.
Thank you very much.
Thank you.
So we now should have
Thank you.
Thank you.
So have a good afternoon. I hope you can get some sun before your next appointment or